Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Dear chairpersons, dear colleagues, it gives me a great deal of pleasure to be talking in today's renowned and very phenomenal heart failure congress. I've been given a very difficult task to speak about the state of art therapy in chronic heart failure in about 19 minutes. So I'll try to do my level best on touching upon the basic outlines and management there. These are my disclosures. So just a quick outline of the talk. I'm going to start with two real-life case scenarios of patients I've been looking after that beautifully demonstrate the whole spectrum of management in chronic heart failure, followed by the outline of management of heart failure with reduced ejection fraction, because that's where most of the evidence lies, or almost all of the evidence lies, in fact. And that's derived from the guidelines and also from recent evidence in novel therapeutic options. And the talk is going to be divided into three sections: pharmacotherapy, devices, and a very brief touch on surgical interventions. Dr. Estep is probably going to talk about that more in detail. And finally, a glimpse into the future outlook of heart failure. So the first case is Mr. TB. I looked after him about 5 years ago. This is a 53-year-old gentleman with no previous medical illnesses, gets admitted via ER with a history of progressively worsening shortness of breath for about 4 weeks, orthopnea and paroxysmal nocturnal dyspnea. He denied any chest pain, and he had a very good baseline effort tolerance. He was working about 70 hours a week as a grave digger. His examination was positive for sinus tachycardia at 110 beats per minute. He was normotensive, saturations were on the lower side, and he was tachypnic. His examination also showed an elevated JVP of 8 centimeters of water, and he was galloping with crepitations, not only in the bases, but really up to the mid-zones. And he had minimal pitting edema at the level of the ankles. His investigations showed a left bundle branch block with sinus tachycardia. Troponin was mildly elevated. BNP was 1050, which was significantly elevated. Normal renal function, CBC, iron profile, and thyroid. He underwent a coronary angiogram because of the left bundle and the elevated troponin, which showed normal coronaries. And this is just a snapshot of his echocardiogram, which showed significantly depressed LV systolic function. His ejection fraction was about 10% to 15% with an apical thrombus. So we managed him with anti-failure therapy, and he wanted to go home very quickly, and that's what we did, and offered him education, brought him back every 2 to 3 weeks over the next 8 weeks, and managed to up-titrate him to bisoprolol 10 milligrams, spironolactone 25 milligrams, prendopril 10 milligrams, and he required only down-titrated his Lasix to 40 milligrams once daily, and warfarin as per INR. 3 months with stable medical therapy later, with no admissions, we brought him back for an echo. He was in functional class 2. His LV function unfortunately stayed the same, but the LV thrombus fortunately disappeared. Now, having class 2 heart failure, severe LV systolic function, dysfunction with left bundle branch block qualified him for CRTD. And we brought him back, so we implanted that, and we brought him back 6 weeks later for a post-implant check. The device check was good, and he was bi-V pacing, which is what we really look for a good amount of time, 97% of the time. And echocardiogram, he was feeling fantastically well, and he was going back to full-fledged work. So we did an echocardiogram, and he was one of these super responders with almost normalization of his ejection fraction. And he was, so this was sort of a happy ending to a bad story. Second one was Mr. AR. This is a 29-year-old gentleman. He was a smoker with history of myocarditis 3 years before I saw him first, and he lost to follow-up, and he stopped all of his medications. He came back with a history of an upper respiratory tract infection, and he was in florid pulmonary edema. His systolic blood pressure was on the lower side, but did not require any inotropic support, but he did require non-invasive positive pressure ventilation. His troponin, again, was mildly elevated. BNP was markedly elevated, and all of his other bloods were fine. ECG showed non-specific STT changes. He underwent coronary angiogram because there was a hint of a transient ST segment elevation at some point, but again, revealed normal coronaries. And this is just a snapshot of his LV function, very massively dilated LV with very significantly depressed LV systolic function. So what happened with him is, again, same story, went home with education, managed to put him up to bisoprolol 10 milligrams, spironolactone 25 milligrams. He only managed to get up to valsartan 80 milligrams twice daily, after which he developed hypotension, so we didn't up-titrate it anymore. He still remained requiring furosemide 40 milligrams twice daily and warfarin as per INR. He had actually a questionable thrombus, and that's why he was anticoagulated. 3 months after optimal medical therapy, again, out of heart failure, still functional class 2 to 3, we repeated his echo, and it was severely depressed persistently. He had a narrow QRS complex, which meant that CRTD was not an option for him, but we did offer him an ICD. As part of primary prevention. Now, he rejected that, and he went on for the next couple of years, coming in and out of hospital about 3 to 4 times a year. He's needed inotropes only once. A lot of it has to do with, again, as was mentioned earlier on, non-adherence to mainly the fluid restriction. So we talked to him about a ventricular assist device, and we did a right heart cath, but his PAPs were pretty elevated, so that was out of question, because that's the only management we have, LVADs as opposed to BiVADs in our area. So he's intermax sort of class 6 to 7, and we've referred him preemptively for heart transplant, and he's put on the list. So this is basically a brief outline of the spectrum of management that we do with chronic heart failure, and I'm going to use these reference guidelines for the rest of my talk, the European Society of Cardiology and the American College of Cardiology guidelines, along with, I know Dr. Mehmet was saying that he's in the committee for the upcoming guidelines of heart failure in the next 6 months, so I'm going to anticipate the kind of changes that might come into place with the new guidelines. So this is a basic roadmap taken from the European Society of Heart Failure guidelines in 2012, and we'll start off with the pharmacotherapy aspect of things. I must say, over the past 30 years, extensive amount of research has been done in heart failure, and with massive landmark trials looking at really hard endpoints such as mortality. And we've come to know three main things when it comes down to pharmacotherapy. The 3 main components of pharmacotherapy in chronic heart failure are ACE inhibitors or ARBs, beta blockers, and mineralocorticoid receptor antagonists. I'm just going to briefly touch on ARNI as a parallel treatment to ACE and ARB. So the first real ray of hope was about 3 decades ago in 1987 with the consensus trial, which clearly showed a 27% relative risk reduction with ACE inhibitors versus placebo. So we know that ACE inhibitors are good for you, and this was validated by several other trials afterwards. Then, a decade later, in 1996, to be very specific, the US carvedilol program showed to the opposite of what was thought of, that beta blockers were a big no-no, that no, beta blockers are actually great, and they work, and they reduce mortality overall. So the 4 beta blockers that are licensed in heart failure are carvedilol, bisoprolol, long-acting metoprolol, and nebivolol. And they've all been clearly shown to have additive effects on improving survival. Then a few years after that, in 1999, the RAL study came to life, and it showed that the addition of spironolactone on top of your ACE inhibitors and beta blockers also showed a relative risk reduction of about 30% in overall mortality. So now we have these 3 drugs, but RALS was only tested for very sick patients, and the fear of the spironolactone was because of hyperkalemia and worsening of renal functions. So it was restricted to the sicker cohorts of patients. This was challenged about 5 years ago when EMPhASIS-HF trial was published in New England Journal of Medicine, and it was looked at in patients that are not so sick, functional class 2, and the effect was sustainable even in those patients, where you see a relative risk reduction of about 22% in overall mortality. So is it enough to start the patient on an ACE inhibitor, beta blocker, and mineralocorticoid receptor antagonist and send them off home? The answer is no. I think it's quite important that we make sure that these patients get up-titrated to the target dose, and that's where a lot of deficiencies are. We should really even if the systolic blood pressure is fine and the patient is feeling fine, we have to, as we've mentioned, it's back to basic pathophysiology. We need to make sure that their neurohormonal system and their sympathetic system are blocked adequately. So you don't stop until you reach your target doses, or if the patient is starting to get symptomatic or worsening of their renal function. In terms of the beta blockers, you don't stop unless the heart rate is sort of dropping below a resting heart rate of 50, because then you're compromising the cardiac output as well. So it's not only about the addition of drugs, but rather about achieving target doses of therapy. So this is a very popular slide by Professor McMurray. I'm sure Dr. Mehmet can nods to that. So these are the foundations that are set when it comes down to heart failure. But is there anything else to solidify the foundation further? And the answer is yes. This is a new agent, the new of its kind, the LCZ696, which combines the old ARB with a neprilysin inhibitor. And neprilysin, which I only recently came to know, is an enzyme that degrades natriuretic peptides and vasoactive peptides. And inhibiting that will promote vasodilation, natriuresis, and diuresis, which is a common theme for patients for heart failure. So does that work? And that does work, and it was illustrated in the Paradigm trial with a beautiful P4 times 10 to the minus 7 value, which is very, very, very significant. However, there's a caveat. This was only tested for chronic stable heart failure, predominantly class 2, and without any significant hypotension or renal impairment. So is there a possible change in the building blocks? I think so. For a particular cohort of patients, ARNI should be thought of as an alternative, and I think that will be changed in the guidelines. Now, additional supportive pharmacotherapy, I'm just going to mention iron therapy. We know from the FAIR-HF trial and from the CONFIRM-HF trial that patients with chronic heart failure, symptomatic heart failure, with iron deficiency, whether they have anemia or no anemia, normal hemoglobin, definitely benefit from repletion of their iron stores. And I think we should really encourage that sort of practice. Now, I know that there are no hard-end mortality outcomes, but patients are getting better and reduced hospitalizations with heart failure. And if people are very big into heart failure outcome, when there is a new trial called the Iron Man trial, and the results are still awaited, and I think will be published before the new guidelines are out. So going from pharmacotherapy and switching gears towards device therapy, which is very close to my heart, it's only been out over the past 10 years. But again, a lot of research has been done in device management. So what do the guidelines say? This is a busy slide, but the take-home message is considered cardio-resynchronization therapy if you have persistent LV systolic dysfunction, severe dysfunction, despite stable, optimal medical therapy for more than 3 months, and your symptomatic heart failure, even if it's functional class 2, so not so sick patients, with a left bundle branch block. Now, if you are a non-left bundle branch block, the results are not so great, but if the QRS is wider than 150 milliseconds, then you would get more preferable results, and CRT is definitely has a role in improving your outcomes. Again, like everything else, it has 2 caveats. If your patient is severely sick, so class 4 heart failure, I think it's an expensive device in this era, so you should really implant it if you feel like these patients will benefit from it and will go on to live about a year, expected benefit, or expected to live for a year or more with a relatively good functional status. And the other caveat is the atrial fibrillation patients. It's not a contraindication, but you want to make sure that they're benefiting from the device by biventricular pacing at least in 97% of the time. So if you don't get that with good beta blockers or antiarrhythmics on board, make sure you have a strategy to start them on or refer them for AV nodal ablation. So if you're not a candidate for CRT, what about an ICD? Because we know that from a lot of data that these patients die from sudden cardiac death as well. So a defibrillator will help these patients. So again, the take-home message is that if you have severe LV systolic function, just like the CRT, despite optimal medical therapy, and you have NYHA class 2 or more, but your QRS does not qualify you for a CRT, that is enough to buy you an ICD. But again, there is a caveat. You need to let these patients know that this ICD is not going to make them feel better, but rather improve their sudden cardiac death. And the patients, again, from the subsequent recent trials, we know that the patients at highest risk of sudden cardiac death from an arrhythmia are not the very sick patients, but rather the class 2 heart failure. So how good are we at at improving the risk of mortality? Well, with the add-on therapy, we've gone from an annual mortality risk from 27.3% to 9.7%, which I suspect with the LCZ as well might reduce a tiny bit, but it's still not good enough. So can we do better if we shake hands with the surgeons? And I know that there are some surgeons in the audience. The answer is yes. And I'm just going to very briefly, because I know Dr. Estep is going to talk about this and is more experienced with this, but Intermax and evidence on heart transplant and evidence of mechanical circulatory support. So heart transplants are excellent, good survival, up to 80% and even up to 5 years, and this has been tested through time. And this is one of the proof of test. This is the oldest living, I checked it on Google recently. This guy has lived for 33 years and is still alive, up to date, as far as I know, and survived, and he's shaking hands with Majdi Yaqub. But the problem is the donors. The donors are quite scarce, and they're very scarce in our part of the world. And so we're not doing as many transplants as we can, and we don't have enough donors to facilitate that. So will we just wait for them to die, or is there a get out of jail card? And the answer is, again, as was mentioned, LVADs. This has been shown to improve survival, either using it as a bridge or to transplant or a destination therapy. And again, the continuous flow devices are better than the pulsatile ones, and the survival is 82% for a very sick cohort of patients at 12 months, which is a very reasonable percentage, I must say. So the issue is, as was mentioned earlier on, we shouldn't really wait till they're crashing and burning. We should really think about it when they're not so sick, because as they get sicker, they won't do as well as later on. So how will it all work? Putting it all together, it'll all work if you have a proper structured heart failure unit. You educate the patients, educate the staff, and make sure you minimize variation amongst practice by putting up checklists, practice guidelines, clinical pathways, and start very early from the admission process. And prevention is key, and I think now we should go a step further by targeting those that are at risk before they get the heart failure, such as the stage A heart failure candidates. And where will the future go? Well, I think ARNI is part of the future. And I think we're still waiting for the AtMosphere trial, but Alice Kiernan as well has a good, I'm a sub-investigator, so there's a conflict of interest there, but that might be something to look out for. And the other question that puts itself there is, where do we draw the line? What's the ejection fraction between HFpEF and HFrEF? And where is it, the gray zone patients, do these therapies work for them or not? And finally, maybe we should be looking at prevention with stage A heart failure. And again, awaiting new updates, this is where we stand today. Thank you very much for listening.
Thank you, Dr. Maryam, for this exclusive summation.